All right, we're going to talk about disruptive behavior disorders today. Most commonly kind of thought of as ODD and conduct disorder, ODD being oppositional defiant disorder. Today, I really want to spend some time showing some examples of how these things work, kind of how different treatments that are evidence supported for dealing with these in children. It's a lot of what you will see in young kids is an oppositional defiant, at least an oppositional defiant behavior pattern. They may not meet criteria, but often parents who come to you for help are coming because their child is not behaving. And this term, this ODD term, gets thrown out a lot, even if it's not always necessary, as we'll see in a second. So let's look at how this should be diagnosed. This is the DSM criteria for ODD. So there are, excuse me, 3 parts. The first 2 being kind of the most important. So part A talks about different aspects of oppositional behavior, and it needs to be for more than 6 months and 4 of the following out of the 8 that they give you. And it needs to be with at least 1 individual. So it does not necessarily have to be, siblings and parents and grandparents and teacher. And it does specify that's actually not supposed to be a sibling. So the first part is angry and irritable mood. So just kind of flies off the handle easily, upset easily, very resentful. The second part talks about argumentative and defiant. So actively refusing to comply, trying to be annoying, blaming others. And the last part is vindictiveness. And they need to have shown evidence of vindictiveness at least twice within the last 6 months. Now there is a note here that for children younger than 5, the behavior needs to happen like almost all the time. For over 5, it can be once or twice a week, and for 6 months. This is important because it's important to kind of separate out typical toddler behavior from actual oppositional defiant, criteria. I have twin 3-year-olds right now, and I hear no often from them. It's an important developmental thing to go through for children to start to assert their own desires. Now, saying no to me when I say, go get your shoes is different than cutting up my clothes or setting things on fire. And if it's addressed properly, that behavior should decrease, right? I also have a 7-year-old and a 5-year-old. I don't hear no from them very often. So some of it is developmentally appropriate. It needs to be very disruptive to be talking about really psychopathology when it comes to noncompliance. So that's part A. So we're talking about angry, argumentative, and vindictive. The second part is it's associated with distress in their immediate context, so with families, with friends, or impacts their day-to-day life negatively, whether that's at school or at home or at work. And they can't be just during substance use or bipolar disorder. Then once you get through that, you decide if it's mild, moderate, or severe. So that's kind of an outline of what ODD should look like. And these are not kids who are slightly impulsive. These are not kids who are, occasionally get into arguments with their parents. This is a little bit more extreme than that. But again, you will hear this term kind of thrown around as if it's every kid has it. So ODD children are persistent, they are relentless, they're confrontational. Again, you need to consider the developmental level. The initial diagnosis will happen before they're 18. If it happens after they're 18, you're really looking at something else. Because, when you're a child is when you have authority. And by definition, these are symptoms that are kind of counterproductive to your ability to follow directions of authority. And it needs to not be better accounted for by conduct disorder. We'll talk about that in a second. There is not a reason why a child should have an ODD and a conduct disorder diagnosis both. Conduct disorder is a more extreme version of the behaviors that are seen with ODD, and there's no point in diagnosing both. It would be like diagnosing, type A and B flu. Oh, and also you have a cold. Well, I mean, no one cares about a cold if you've got A and B flu together, right? You're miserable. So it's conduct disorder. If there is conduct disorder, you should not also have a separate ODD diagnosis. Now, a child can get an ODD diagnosis first, and if not addressed properly, it can definitely progress into conduct disorder, but you should not have both at the same time. There's no reason for that. Also, you may not see some of the symptoms actually in your office, just during a normal clinical intake, because it's really based on the boundaries that the child feels like they can push. And sometimes, when they're in a new situation, they may not demonstrate that. Sometimes they will, but it's really more about how they act at school and at home, and just a significant environment in their day-to-day life. So about 3% of children meet criteria for oppositional defiant disorder. It's not that common, but it will feel more common to you because of how many children you will see who that's what you're looking at, because again, they're more likely to ask for help when they're disruptive and things like that. There is a large overlap with ADHD. So you'll notice with the ODD that they don't really address specifically impulsivity, hyperactive behavior, or inattention. So if they've got the criteria for ADHD that we talked about last time and the criteria for being angry and vindictive, then you're looking potentially at both. There's quite a big overlap, and a lot of it does come down to self-regulation issues. I want to show you guys some videos of some treatments for oppositional defiant disorder. There are there's actually 3 really common treatments for this type of behavior. They all came out of the same graduate school under the same advisor. And the first 2 that I'm going to show you are PCIT, Parent-Child Interaction Therapy. I know a little bit more about this because I'm trained in it and I administer it. This is one of the therapies that I will actually provide still. And Dr. Campbell and I train across the country in PCIT. The second one that I'll show you is called The Incredible Years, which also came out of that same school of thought. And then the third is The Strong-Willed Child, which I don't have a video of, but you may have heard of. All 3 of these are really focused on similar components. They are parent-led, so it's not you as the clinician fixing the child. It is you working with the parent to empower the parent to have those skills and then to be done with you. You're not really fixing anything directly. They involve coaching. You'll see in the PCIT video how that works, but ideally you have a microphone, you're in a different room, you're watching them through a 2-way mirror. They're hearing you and they're learning how to communicate better with their child. They all involve a ton of positive reinforcement, lots and lots of praise, lots and lots of individual attention, and then only later do you even talk about punishment. And then the punishment is very structured, consistent, all of those things. So let's watch a couple of videos of PCIT, and then we'll talk more about it. If this will get bigger, let's see. There we go.
She was unmanageable at times. She would throw her head down, she would flip, she would fight, I felt like I was not being a good enough parent. It was scary for me because I knew I did not want to go down that road is also a responsibility for the mental health. We also recognize that 90% of what that child is outside of the back. So this is a child on the well-being, and to address health and well-being changes and what's research is translated into that. Oftentimes it's continuing on with so much more research in the laboratory that we will use these institutes to adapt and then integrate programs within the community space and then help children doctors actually take those programs and adapt them to perspective or application.
Okay, so a few things just to point out about that before we move on to the next video. You'll see that Sophie is very young. The average age for PCIT, or the most research validated age, is between about 3 and 6. Sometimes a small 7-year-old. The reason I say small is because you may have to have the parent physically lift them and put them in timeout. And some 7-year-olds are pretty big. You saw that the mom mentioned 5 minutes a day. So an important part of kind of behavioral practice in general, but definitely with PCIT, is that the parent is responsible for homework. It's not your job in 45 minutes to undo 5 years of bad parenting practices. So they spend 5 minutes a day doing a very structured play activity with their child. There's rules for it, which you go over with the parent. You explain all the rationale behind how they're going to be talking to their child. It is based quite a bit on the play therapy mentality of letting it being play-based, obviously, letting the child lead, not demanding anything of them or asking questions. And then in session, you're only in the room with the child for a few minutes. The rest of the time, it's just the mom and the child. they're playing, or the dad and the child or whoever, they're playing together for 45 minutes or so, and you are coding them and coaching them. And it's just transferring of skills, right? The therapist has the skills, they're transferring those skills to the parent. The parent then is empowered to go home and do it. And so it's not at all about um, the power necessarily of the therapist as much as the transfer of skills to the parent. I mean, sorry, the power of the therapist. Instead, it's about transferring those skills to the parent, because the parent is the one that needs to be able to control the child on a daily basis. Getting PCIT trained in order to be a PCIT therapist is a 5-day training, usually. 5-day training and then a year of follow-up calls where you're getting consultation, kind of like supervision on your cases. So it's not a, go for a few hours, read a book, and then you're ready to be a PCIT therapist. It is a pretty intensive process, and it's that way because it is a little bit more complicated than sitting and asking a child, why are you doing that? Or coloring with a child and trying to gauge their emotional stability by how well they're coloring or how well they're listening to you. And so it is a little bit more in depth. It's very scripted. There's a protocol that really outlines for you what to do every step of the way, and that keeps it consistent, and that's what keeps the research so strong. Watch one more example, and then we'll talk a little bit more about it. Okay. This is a little bit more of an extreme example of a situation where the courts actually got involved due to child abuse. And this is not uncommon with PCIT because it does teach so many pro-social skills as opposed to abusive behavior. So quite a few of the parents that start doing PCIT have had issues in the past with physical abuse. One important kind of thing to point out, though, is that you would never do PCIT with a perpetrator of sexual abuse because it is based on building a strong relationship and building warmth, and that's pretty much grooming. Uh, and so you wouldn't do this with someone who'd been accused of that kind of abuse. But with physical abuse, it's great because it really teaches alternative behaviors that teach the child what to do, that keep the parents from losing control. So it's really a really strong alternative. Okay, the last video that we'll watch with this is The Incredible Years. This is one that it works at home and school. It's again, you'll see a lot of the same principles. We'll watch this and then talk about it.
Mark in Drogheda, and his school is just across the road from his house. Luckily for him, Marcus loves going to school, but it wasn't always like that.
Okay, so that was in Ireland.